I'm actually one of those people in the situation with a parent who is living with me. I moved my mother in a year and a half ago. So what I'm talking about, I'm currently living, and I just want to show you a few minutes of this video, and then we're going to get into my discussion. You might notice the fashion is a little dated, but the message is just as relevant.
I'm Dr. Nancy Snyderman. No matter what we like to think, we're all going to die someday. Now suppose you're in a hospital. You've written a living will, said what you want, and more importantly, what you don't want when you're dying. Well, what if the hospital or physician doesn't pay attention to your wishes? In the next hour, this audience will look at some videos about families struggling with end-of-life decision-making. Then we'll talk about how to have more control over what happens when we're dying. Here's correspondent Betty Rollin.
When it comes to dying, we're not talking enough. Physicians aren't listening enough, and people are suffering needlessly painful deaths. In this program, we'll meet some remarkable people who are confronting death. We've chosen mostly women because the fact is we end up making most of the tough choices for ourselves and for others. Let's visit the Abril family. 4 months ago, Juan Abril had a heart bypass, followed by a severe stroke. Now his kidneys are failing. He's on a respirator. He has a serious infection. His wife has gathered the family at the hospital.
It's been 4 months now that he's been sick in the hospital. To see our father like this suffering is very difficult. We love him so much that we were willing to do anything for him. Tatay, tatay, tatay. We don't know what to do. We don't know what to do. We don't know what to do. Just to wait.
There hasn't been any improvement in his condition, and his kidneys are starting to fail. He continues to run fever, so we suspect infection, and he hasn't responded to any antibiotics. He's been basically ventilator dependent for over several months, and the pulmonologist has been managing his ventilator and has been talking about possibly stopping the ventilator. And the question is whether that treatment, futile that it may be, is warranted versus allowing him to die, which is probably the inevitable outcome. Well, what I'm going to speak to the family about today is I'm going to talk about options that they have. Okay. Are you ready to sit down and talk? Yeah. Okay, why don't we go on down? Well, it would be easier, ideally, if I knew what he wanted. And unfortunately, I can't talk to him. I have to speak to the family in order to get from them what they feel he would want. All right. He's been on the ventilator for a long time. His chance of coming off the ventilator by himself,
there's nothing we can do,
is virtually zero.
It's over, right? It's over for him, right? I mean, we cannot give him any more chances that, you know, he's going to live his normal life again. No more.
No. From your father's perspective, what do you think he would want to have done? Say, if he could tell us.
We were not able to ask him about, you know, what he really wanted, you know, in this kind of situation. So, our, you know, aspect.
You know what makes it difficult is because prior to the surgery, my sister and I were very optimistic. But my sister was thinking about creating a living will, but she thought to herself that she didn't want to jinx it. She didn't ask my father to create a living will. My father said that he would endure everything, anything. I had the feeling that he wanted to live.
What I'm thinking is he will not like to live anymore in that kind of situation that he was paralyzed from here to the bottom. I think he will not like to live like that. So
these procedures are all, you know, it's useless. I mean, he's going to die anyway. That's for sure, right?
Yes.
And our main concern is not to see him suffer no more. He's going to die anyway. What's the use?
My opinion on that is that I don't want him taken off the ventilator. I want him to die naturally.
Okay, well, that's, you already said that that's artificial. There's no right or wrong answer to this, okay?
Go ahead.
It seemed like we're going to be killing him, you know?
You know, if in case that we should have an agreement of taking off the ventilator, you know, we will be burdened by the guilty feelings that, you know, we took it off. You know, it's in our hands right now if he's gonna leave or not. So
we'll talk about it, maybe. We'll talk about it and let you know what will be our decision.
Mother, I don't know. I really don't know. How will I deal with this situation after he's gone? I don't know what will happen to me. I really don't.
How many people in this group here could identify with what the Abrils went through? How so?
I was struck listening to this. My husband died a few months ago of pancreatic cancer, and I am astonished to realize that I have not made a living will at this point, even though he made one and it was very clear, so on. So
and were you relieved that he had one?
I was very relieved that he had one. He was very clear about this. But what strikes me in the whole experience is I kept feeling as though we had to make decisions simply about how much treatment, whether or not to have a tube. And there was no one who really could tell us what to do. And there were many different doctors of different parts of my husband's body. But we still were the medical, we were the ones who had to make the decision, which seems to me sort of mad.
Has anyone else in this area, I saw you nodding earlier.
My husband was ill for more than 9 years. And at that time, when the hospital called me at 2:30 in the morning to say they wanted to put him on the respirator, I found it much more difficult to say no than I had expected. I did say no, he did recover, but once he recovered, we sat and talked very specifically about what he would want. So when he suffered a massive stroke a year later, it was easy for me to say to the doctors, you can't do anything.
I saw yes, ma'am.
If I would have known 18 months ago what I know today, my husband wouldn't be a victim of resuscitation. They asked me to go home from the hospital where I brought him with a stroke. And he had his living will filed in the records. And I asked before leaving the floor at 11 o'clock in the evening, you be sure that there is a living will. When I came back in the morning, he was after cardiac arrest resuscitated. He couldn't speak, a man who speaks 5 languages, and I have him home now for 18 months. He's the victim of resuscitation, and that is horrible. That is deplorable.
Could you pass the microphone to Dr. Ehrenheim for a second? As a physician at Mount Sinai, you've seen more than your fair share of people come in crises, and I watched your face during that piece, and it had a very knowing half smile on it, like this is something you've seen played out before. Do we as physicians add to the confusion?
I think we definitely add to the confusion, but I think our worst crime is that we don't really give enough information to patients. And the Abril family was, all of them practically were expressing something that I've heard a lot. If we stop the respirator, I'm going to be killing my father. It's going to be my fault. And I think it's really important, among the many things that we really need to tell patients and their families, that they're not killing the patient. It's the disease that's ending the person's life. They're being given the opportunity to help make a decision for their father or their husband, but it's laid a tremendous burden on them.
So while he's getting my PowerPoint up, what I'd like to tell you is a story about a guy named Billy Graham. And I heard that early on in his ministry, he was at a very small town getting ready to talk to a group of people that night, but he needed to pop something in the post office. He was going to mail a letter, and he didn't know where the post office was. So he went out on the street and he said, there's a little boy out there, and he said, can you tell me, son, how to get to the post office? And the little boy goes, it's down the street, around the corner, and over here. Thank you, son. And by the way, you're welcome to come to my church service tonight, because I'm going to be there telling people how to get to heaven. And the little boy looked up at him and goes, I don't think so. You can't even find your way to the post office. Which, actually, when you think about it, though, perception is everything. And one of the things that we get to do in the community, in the world of healthcare, particularly end-of-life care, is we get to be myth busters every single day. Because there are a lot of perceptions about what it's like to have those kind of conversations. And the goal of classes and discussions like this is to prevent what the Abril family went through in the first place. So that if we could go back in a timeline and talk to them and eliminate that fear of that jinxing from creating a living will, we could have had an entirely different outcome. What they recognized back in the 90s was here in the US, people were not having good end-of-life experiences. And the government decided that what they would do is take charge of this issue and give us an opportunity to make our own decisions in end-of-life care, and everything would be all better. Once we legislated it, it's going to be wonderful. And the result was nothing better happened. And part of the reason why, having been in healthcare for over 25 years and 12 of it in hospice industry, I think part of the reason why is because we didn't teach healthcare professionals how to do this, how to have these discussions. If you were to come in an outpatient eye surgery, I might say to you, or sign up for my program, in the event that your mom's heart and lungs were to stop working, would you want us to do everything to try to save her, including CPR? We're not even presenting it right, because when we do it that way, the assumption is if you say no, we're going to do nothing. We have to change the whole way we're talking about this language. And I'll show you what I mean by that in a minute, because you guys might be the ones helping the healthcare professionals you encounter do that. So advanced directives, what are they? Living will, durable power of attorney for healthcare, but it's more than just putting the papers in place, it's having the discussions. When my husband passed away 11 years ago, we were in the process of putting the papers in place. We'd had the discussions, but we didn't have the papers. But it was a world of difference for me to be able to know what he wanted and to be able to carry it out in the way he wanted. It doesn't take your grief away, but what it will do is it removes the guilt and all the other things associated with what if, or did I do the right thing? And there's a whole other piece of planning in addition to the advanced care health directives, and there's a whole financial, what am I going to do with my estate? And the really good news is I don't have to talk about that part today because we've got some people to do that. So here are some questions I use, and that if you're talking to loved ones, I think you can use, that are gentle. They're not pushy, and they get the dialogue going. The first one I say when I walk into the home is, tell me, what's quality living to you? And how can we best partner with you to make that happen? The answers I get are as creative as the individuals I encounter, because no two people define quality exactly the same way. One gentleman we worked with said, I used to be a gardener and I used to get out to that gazebo for a burger and my drinks every night, and I can't do that anymore. So if you really care about quality, maybe your people will get me out there. So Mondays and Thursdays became his burger drinks night on the gazebo. Somebody else said, I can't get my dog Fluffy to the groomer anymore, and that would make a world of difference. I had one grandmother who used to do Friday night overnights with the grandkids, and she used to do story time, and she knew that that day was going to end. So we created a whole series of 12 weeks of stories, so that when she was gone the first 3 months, the kids still had the Friday night stories, even if they didn't have her physically present. So, what does living well mean to you is really important to consider. And then the other question I always ask is, Mom, are there any circumstances you've heard about through the TV or the news where you found yourself saying, I wouldn't want to live that way? It was 8-10 years ago, back when the Terry Schiavo case was getting a lot of media publicity. That had a lot of attention. And if there's one good thing that came out of it, is it got people talking about, this is what I want, this is not what I want. The third question I ask is, do religious values influence your treatment decisions? These are very gentle questions that can get discussions going in a lot of ways. And then the last is, would you want treatments that might prolong your life if you could no longer swallow, or if you were no longer able to think for yourself and not likely to regain consciousness? The time to have these discussions is way before the crisis, so that if and when first of all, it can help you prevent them, but if it does occur, you know exactly what to do in them. Withdrawing and holding treatment. That can be a really sticky situation, but the bottom line is hospice is not euthanasia. We are not Jack Kevorkian. We are not here to prolong life or to abbreviate it. We're here to partner and come alongside and let the natural process take its place. These are examples of what you might consider life-sustaining treatments: artificial nutrition, dialysis, antibiotics, pacemakers, ventilators. Whenever I look at those and I'm talking to patients and their families, what I always would encourage you to do is weigh the benefit versus the burden. I have a brother who survived a very serious auto accident 30 years ago, and he had a tube feeding for 9 months. It was very beneficial for him. I have a father who was at the end stage of dementia 5 years ago and had a tube feeding for 3.5 weeks. All it did was prolong his death, not his life. And so this is not an either or, black and white, good or bad. You've got to look at it in the context of the individual situation. And there's a great book out there, $4 or less on Amazon. It's called Hard Choices for Loving People by a guy by the name of Hank Dunn, D-U-N-N. It costs about $4, and you can read it in 1 to 2 hours, and he's a chaplain in long-term care for well over 20 years who's seen these discussions. He does it in great lay terminology and weighs the benefits versus the burdens of everything in simple, easy to understand language. Code status. They talked about resuscitation, and I mentioned a minute ago that we don't always do a very good job in healthcare discussing it. So I try to take it this way. Let's say you were to come in, and Trina were to come in, and she'd had her mom in the program, and I'd say, Trina, in the event that your mom's heart and lungs were to stop working, we have several ways we can handle that. And I'd like to share each of them with you, and you can tell me which is most in line with her personal philosophy. Now, the first way is we do everything in our power to provide comfort to her. And that means if she's having trouble breathing, we can give her oxygen and medicine. If she's having trouble with pain management, we'll give her medicine for that. If she's having trouble with emotional or spiritual distress, we'll bring supportive services in for that. But option A is we do everything to keep her comfortable. We don't do anything aggressive, but we do make sure that we manage that. Then I go on to the other options, which is where you would, kind of press in on the chest and do the full code DNR status. I want to tell you something. A lot of people, when they're terminally ill, might come into my program initially and say, yeah, I want to be a full code. I want you to do everything. And 99% of the time, the reason they say that, and I ask them, so tell me, what is your perception of the results of that when we do it? Is because they have a misperception, like the little boy with Billy Graham. They think that once we do it, just like Grey's Anatomy or ER, they're going to pop up and everything's going to go back to normal and life is going to be rosy and wonderful. And when I tell them the reality, the true stats are that people that get CPR when they're terminally ill usually end up with a punctured lung or cracked ribs. And the likelihood that they return to their normal state of living isn't very high, like less than 2 out of every 100. And it changes things because they were thinking, I said, are you aware that that's the fact as we know them statistically? If you look at CPR when it was started in the 60s, it even says, this is for people who have otherwise been healthy or maybe suddenly had a heart attack or a swimming accident. This is not for people who've been ill for a long time. In our society, we've swung the pendulum so far over here that we have to do it on everybody legally now, unless we have what's called a do not resuscitate DNR order from the physician. So hospice and hope. One of the biggies I get is, yes, you can come talk to mom about hospice, but whatever you do, don't tell her it's hospice, take your name badge off. This shall be a sign unto me that there's a discomfort that I need to talk a little bit more with the caregiver about and maybe work through some of that. Because there's the myth that when you sign up for hospice, it's the place you go to die and it's where you give up hope. And here's the truth. It's not about giving up hope, but it's really about transitioning it. I can't go back in a time machine 30 years and cure and change these health habits or whatever it was, or these genetic issues. But what I can do is say, I can come alongside where you're at today and say, what's important to you? And let's make this work to live as long as possible. We have a research study We did 2 groups, and this has been repeated 3 or 4 times. But we have 2 groups of people, same patient, same diagnosis. Group A signs up for hospice, Group B does not, for fear of dying. Which one lives longer? Group A. Now, a lot longer, average of maybe another month or so, 30 plus days. It's not a lot longer, but it is longer, because I think what happens is they finally have reconciled, this is where I'm at, and I'm going to enjoy every moment to the best of my ability. And if that means I do this, this, and this, and if that means I stop having to check my blood sugars, then that's what I'm going to do. Some of them have done a lot more living than I have. Another myth, payment. Hospice is really, really expensive, so I'm not going to sign up for it. And here's the real story. The real story is if you have Medicare Part A, hospice pretty much covers all of it. It covers the nurses and social workers and chaplains and volunteers and doctors coming out. It covers a lot of the meds, most of the supplies and medical equipment, and everything we need to manage your care. And there's some private insurances that will cover it 100% or 70% or up to $1 million, but that's up to, we would check that out with each private insurance for somebody who was on a private insurance plan. But here's the other piece. There's, well over 20, 25 hospices in this city. When I work in Texas, I've got over 100 that I deal with. It's a competitive industry now. And the truth is, we have to do our due diligence, and we're on the stock market now, so we have a fiscal responsibility to manage our resources wisely. And the really cool thing is when we do that, if we have somebody that doesn't have the kind of benefits that they need, we can cover those things. You know, there was somebody recently that had a really bad situation with bed bugs in her apartment and some government housing, and she was in misery, and she was on our program. We were able to pay for that, and there are things you're able to pay for and do when you do your due diligence for other people too. Hospice is a place. We all know about the place in Blue Ash, and it is a place there, and there are several others, but the reality is the inpatient unit is probably less than 5% of all hospice care gets done in an inpatient unit. 95% or greater gets done in the place that the individual calls their home, whether that's a private residence, a skilled nursing facility, or an assisted living. Hospice is only for certain patients, and usually the ones that have cancer. I've gotten that a lot. Not true. Actually, when I started in the industry, and this makes me feel like I'm really dating myself, way back when, I would say 75 to 80% of our patients were cancer patients, but today, 20 to 30. There's neurological disorders, kidney disorders, lung disorders, a lot of dementia, a whole lot of other issues are coming into hospice now than in the past. Pain medicine. We're not going to sign up because it's going to give the people lots of morphine, and then my dad is going to die sooner because they're going to dose him up with so much morphine. And the reality is that we use morphine and other pain medicines to keep patients comfortable. It doesn't promote death, but we don't promote death or euthanasia. Interesting thing about morphine, it does have a scary reputation, even among clinicians that aren't familiar with end-of-life care. It has a very short half-life. So if somebody's having some issues with pain management, it's not uncommon for us to increase their dose and for them to be sleeping, and we go out to do a visit, and they're like, you got to do something. Dad's been sleeping all day. We can't even talk to him anymore. He's too dosed up. And then about day 2 or 3, Dad's adjusted to that dosage, and he's already awakened back again. Oftentimes, though, there are times if somebody's near the end of life that they don't do that. And so then there is the assumption made that there's a correlation that if we hadn't given them the morphine, he'd still be alive. Chances are that's probably not true. Hospice and food. Here's a biggie. Jeannie, you've got to do something. Mom's starving to death. We've got to get a tube feeding in her. What are we going to do? Hospice, we don't want to sign up because hospice stops feeding patients, and then they become dehydrated and they starve to death. Here's the real story. The real story is, you just told me you put your mom's favorite barbecue and Grater's raspberry chip ice cream in front of her yesterday, and she only took 2 bites. The definition of starvation is withholding food and fluid from someone who wants it. When you're putting it in front of her and she's not taking it, tell me, what do you think that's saying to you? And it's not uncommon when the body's shutting down for the desire to eat to be less. So the best way to handle that, because we all want to feed them because that means love, is to rechannel that energy and maybe work on going through some photo albums with them. Maybe give them a massage or a foot rub, something different other than pushing on the food, because has anybody here ever had the flu? I don't know about you guys, but when I'm watching TV and a Wendy's commercial comes on and I'm not feeling good, I don't even want to look at it. And when bodies are shutting down, they don't want to look at it. It's actually a burden to them. Let them tell you. Let them tell you what they do and don't want. And sometimes I've seen, because a family member is so emotionally distressed over the fact that they're not eating, I've seen patients work really hard to try to put a good front to do it for them when they're tired. And they don't, and they want the permission to say, no, you don't have to. So, in a nutshell, what I'd like you to consider is having the discussions with each other and with yourselves now, because what's really important is, one of my colleagues, you might be surprised, I always wanted to be in the ride home after one of these presentations, because that's when the really good, just like the meeting after the meeting is the real meeting kind of a thing. My boss went to an attorney not too long ago, and they were getting their estate put together, and they were getting all their finances in order. And he took the liberty, when she picked the paperwork up, of doing their advanced care planning and their living wills and making each other that without even having the discussions. And her husband had been an avid runner his whole life. Not her, but him. So she says, honey, if we were driving home, we got in a car wreck and I got injured and the doctor came to you and said, unless we amputate both her legs, she's not going to survive, what would you say? He'd say, I'd say let her go. Because, his legs, he's a run. She's like, wrong answer. I think I need to get my dad to be my power of attorney for healthcare. So I'm just saying, don't, and that's what I've seen too with some of the patients I've worked with. They may have 5 children, but child number 3 is the one that lives in town and is the one that's made it the easiest for them to have honest discussions with. So maybe child number 3 ends up being appointed the main one to do the decision making. You might be surprised the Pandora's box that can open up sometimes when some of these discussions do occur. In order to do this presentation, gosh, it was 11 years ago, I was sent to Wisconsin to a training seminar by Gunderson Lutheran, who's way ahead of the ballgame in advanced care planning from the rest of the country. And part of what we had to do before we were allowed to graduate and do this was we had to create our own advanced directives. I had to create my own living will, my own durable power of attorney for healthcare, and I had to have those discussions with the people that are my loved ones on what I would want to happen. So it's really easy to sit here and say, this is how I want you to do it, and Mike and Shelley may talk about this more. When it comes to finances, you're going to need an attorney. But I don't know if you're aware of this, when it comes to a living will, you do not. A living will for a durable power of attorney for healthcare does not require an attorney. It requires a signature of 2 people that are witnesses and some other things. The financial piece does. Now, it just so happens that a lot of attorneys are gracious enough to go ahead and do that part as well. But if you look at the paperwork and you can download it, it's actually quite simple to do. And you can get really creative. I had one gentleman that had a stroke, and they had given him tube feedings, and he had 12 weeks to recover, and he had rehab, and he did recover fully. Was amazing. And he got his tube feeding taken out and he was back to normal. So when he did his advanced directives, he says, I want to put an addendum in here. I want to put an addendum that if something like this happens again, they at least give me 12 weeks, because this is my experience with the tube feeding. And if it doesn't work, then they can go ahead and stop it. Well, guess what happened? It happened. We had him on a tube feeding. It happened to be a nursing facility with religious principles that you can't remove the tube feeding because it's never simple. And so we were at week number 13. There was no improvement. We were like, okay, we want to honor his wishes, yet the facility he's in is saying, no, we can't do this. And so the way to honor both was to transfer him to another place that would allow that. And that way we didn't put this facility in jeopardy going against what they believed in. And we also allowed the opportunity for him to have what he wanted.